Hi, it's Dr. Centeno, and thanks so much for inviting me to speak, Dr. Dallo, Dr. Bernaldez. I grew up with my father speaking Spanish, my mother speaking English, so regrettably I know some Spanglish. I think I've tried once before to give this talk in Spanish, but I think I'll stick to English this time. Thank you. And I want to share an interesting topic. There was some initial thought that I might talk about culture expanded cells, but I wanted to sort of back up a little bit and actually talk about something that I think is more foundational, and that is seems like a pretty big disconnect between Europe and the United States on the concentration of PRP and the dose of the PRP that we should be using. And so I wanted to go there because I've talked to lots of Europeans at conferences where I lecture, and many of them are using kits where they can only get to 2x, maybe 3x PRP, and they're satisfied with it. But the experts in the US are using much higher concentrations than that. So I wanted to go into this a little bit because I think it's important, and it's an important foundational topic. So the title of this talk is, does the concentration of PRP cause a higher likelihood of clinical trial failure? As far as disclosures, I'm the founder and chief medical officer of Regenexx. We've got about 150 clinics in the US and a few scattered around. So you may have seen large randomized controlled trials with negative PRP RCT outcomes and related editorials, right? There are a couple large trials out there that seem to show that PRP doesn't work. Now that's very different than the clinical outcomes that we experience every day in our practices. So what's going on there? And I think one of the things that you can certainly focus on is this issue of PRP dose, because I think it's absolutely critical and it explains these trial failures quite nicely. So there are now a number of publications out there showing that PRP dose is directly related to outcome. So what do I mean by that? We're going to get into it, but there's 7 different papers here that tie that together. Many of these are RCTs. Some of them, like the publication that we have, is a foundational lab study. But we have now some steam behind this concept. So one of these is the Barrionuevo Study, and it's interesting. It's a 2024 study, and it shows that if you look at the mean platelet dose of randomized controlled trials for NEOA, and you look at that dose versus a positive trial and negative trial, you can see here that there's a substantial difference. The trials where they're using higher dose platelet-rich plasma are much more likely to be positive. In fact, you can see this very different dose between a negative trial and a positive trial. So pretty interesting stuff, right? It certainly seems to be creating the narrative that dose is incredibly important if we're going to be using PRP. It doesn't mean PRP won't work if you use a low dose. It just increases the likelihood that it's going to work if you use a high dose. Now, there are 2 different ways out there to look at PRP platelet quantity. One is the total dose delivered in billions, which can be helpful if you're doing multiple injections, for example. We have tended to use the concentration of platelets from baseline because since we had a lab process, we knew exactly how much volume we were taking out. So we knew by volume what the concentration factor would be, meaning 2 times, 3 times, 5 times, 10 times the baseline platelet concentration by volume. And we know, based on a paper we've published and others, that if we get down to brass tacks and we start looking at why platelet dose would matter, that the higher your growth factor concentrations are, the more cellular proliferation you see. Now, we also know based on our study that that's age specific. In younger patients, it doesn't make such a big difference. In older patients, it makes a much bigger difference. So that's an interesting thing, right? And it makes sense. Higher dose, more growth factors, more proliferation, bigger clinical effect. Now, one of the things to consider if we're going to be talking about dose and we're treating something like knee osteoarthritis is that if you think about dose, it's not always going to work out well for you. Meaning, if you have a patient with a large effusion, then the concentration of growth factors is going to be less. So I've drawn 3 different knees here, right? And if we look at this one right here, then we've got sort of the normal knee. It's got maybe a couple cc's of fluid in it. You put 20 times concentrated PRP at 3 cc's in there, and you've got a very high concentration of growth factors, which are the red dots. Now, if we go to the middle condition, it's a little different. Now we've got a swollen knee. Let's say it's got a 20 cc effusion. And then you put the same amount in, the same dose, but your concentration is quite different. Just look at the red dots. Now your concentration is far lower. So you've got fewer growth factors per cc, so your effect is going to be less. And then obviously you can also do low dose PRP at high volume, and you're going to do the same thing. You're going to reduce the growth factor concentration. Really what this means is you want to use higher dose at lower volume, and you want to drain those effusions before you inject, because we know again that the concentration of growth factors is critically important. And one of the things to recognize as we talk about all of this a little bit is some of the work done by Jeremy Magalon here. And that is, if you look at all these different systems that are out there, and a common one, the 2 most common I see being used in Europe are the Regen PRP and Arthrex ACP. And if you look at their platelet capture efficiencies, they're pretty poor. 55% here for Regen PRP, for Arthrex under 50%. So they're not capturing many of the platelets that are there. And if you look at their final concentrations here, a factor increase in platelets, for the Regen PRP, let's see here, you're only at 1.6x, pretty bad. And for the Arthrex, you're only at 1.3x. So very low dose systems. Now, interestingly, like I said, our work showed in the lab that if you use something like this in a young patient, it's probably going to work. But as the patient gets older, this is not going to work. And that's why I think we see many of these trials fail, because frankly, they use one of these 2 systems and the concentration was very low. Now, the good news is that as of April of last year, I'll do it again April of this year, these are all the randomized controlled trials that we had for PRP. There are 144 of them. Amazing, right? You can see them listed here off on the left by clinical indication. You can see off on the right the various conditions that were tested. A green circle means here a positive trial. A red circle means a negative trial. And most of these are injection-based. But pretty amazing. The problem is the literature only reports the platelet dose in about 20 to 30% of these. Now, I asked the question, and we're getting pretty close to publish this one, but this is some pre-publication data. can you back into a probable dose even when they don't report the platelet dose? So that's what I did here in this little thought experiment that's now turning into a more formal systematic review that we will submit for publication this year. But basically, we backed into the dose here by just looking at the amount of blood that they took and the amount that they injected. You can't get to an exact number, but you can draw a line in the sand and say that these are low dose and these are high dose, right? The low dose ones would be you didn't take much blood and you didn't inject much volume. The higher dose ones are you took a lot of blood and you injected a relatively low volume, meaning high concentration growth factors. So again, if, for example, we're looking at a blood draw of only 8 mLs, and there's a final PRP injection volume of 4 mLs, and we know the platelet capture efficiency is well below 100%, it's probably more like 50%, then that's very likely below 2 times concentration, for example. So based on this analysis of studies up through July 2023, and we've now updated this for the newer studies, at that time we had 107 total PRP MSK randomized controlled trials with 11 failures. Pretty good. But using this methodology, meaning backing into studies that used less than a 2 times PRP, 60% of the RCTs were failures that used this low-dose PRP. 5% of those RCTs, only 5%, were successes. And there was a 12 times greater risk of study failure if you used under 2x PRP. So in conclusion, using PRP concentration below 2x is a serious problem. Now, again, it can work, right? If you've got the right patient, if you have a young patient, you don't need high dose. That's what our basic science data showed that we published. But most of us probably don't treat a lot of young people. They don't get injured as often as old guys like us. So if you're an old guy like me, you're more likely to get injured, you're more likely to seek care, you're more likely to get PRP. That means that most of the patients we're going to treat are going to be older and going to need this higher concentration. If we look at the total platelet dose, we probably don't want to be under 3 billion. So we know we certainly don't want to be under 2x. We know that we don't want to be under 3 billion total dose. And I think one of the things we need to do is to start educating even peer reviewers for studies on this issue, because they're not picking it up, that there's a difference between a 1.3x PRP study and a study that uses 7 times concentration, etc. And then you may want to consider all of this when you look at your own clinical practice, right? At the end of the day, if you're using low-dose PRP, I would encourage you to try using higher-dose PRP. And I think what you will find is in your middle-aged and older patients, you will start to see better results. You will start to see more treatment successes and fewer treatment failures. So thank you so much again to the conference organizers for inviting me. As you know, I now spend a couple months a year sailing in the Mediterranean and thereabouts. So I've been in southern Spain along the coast. Beautiful. We will make our way back there, hopefully pretty soon. And maybe I can come in and next year, the year after that, attend in person. But thanks so much for watching this presentation. And again, I encourage you to try higher dose PRP because you may see better results than you're seeing now. Thanks so much for watching and have a great day.